a presentation ready for Dr. Abdulrahman, and he will present his case with the title of Suicidal LV post-TAVI. Abdulrahman Alqahtani is an interventional cardiologist, and he was surfing in Damascus, Syria last week for charity work, and he did more than 110 cases there. So great job, Abdulrahman, brother.
So thank you, Dr. Fawaz. Hello, everyone. Good afternoon. My apology, my voice is not that clear, so slightly raspy. So forgive me for the images. We had some problem with the images, but we'll do it as much as we can. We have only 6 minutes to go. So basically, this is a case I did about 5 months ago, and I was in a private hospital, so we don't have the normal setup and normal support that we would have access to. So keep that in mind. You're kind of flying solo in those places. So I had this case, 93 years old gentleman, background history of dyslipidemia, hypertension, type 2 diabetes, came to me with pre-syncope and also history of heart failure and angina. When I was working on also Parkinsonism, so we sent him for a routine workup. So those are the images. They're not the best, but basically what I'm gonna show you. So LV is normal function, but there is concentric LVH. The septum measure about 13. You could see maybe here you could see flail cardiac and partial prolapse of the anterior leaflet. The valve is calcified, but you don't see it very well here, but we could see some MR. This image is not great. We'll move to the next one. And here we could see there is also at least moderate to severe, but it's to be honest, severe MR due to that flail anterior leaflet. So he had this severe MR, also severe AS. We don't have the gradient here, but I will show you in a second. On top of that, also he has severe pulmonary hypertension. So this patient turned out to have normal ejection fraction, concentric LVH, a septum of almost 13, severe aortic stenosis, mean gradient of 44, mild AI, and severe eccentric MR due to partial flail anterior leaflet. On top of that, he also has severe pulmonary hypertension. So part of the workup, we did his angiogram. So angiogram showed a codominant system, normal left main, normal LCX, normal RCA, but there is disease in the mid LAD, almost 90%. That was treated basically with one stent, basically right away, just single stent, and he did well. Okay. So after discussion that the patient's given his symptoms, pre-syncope, and everything he has, it seems that his AS is driving most of his problem, and we elected to deal with that first before considering anything for the mitral valve. So this is his CT analysis. So the valve perimeter is about 70, mean analysis of about 22. The height of the coronaries are good, sinus of Valsalva is good, everything looks good from the point of view, no issues with access. Those are the images. You can appreciate the LVT is slightly smaller than the annulus, but otherwise fine. Now a lot of calcification in the aortic valve, but everything else is fine there. So the thought at that time that we will handle this patient first by considering him going for right femoral access, transfemoral TAVI, and given the size of the annulus, we chose to go with 26 evolute FX, and that was the plan. We had no reservation, we had no concerns, to be honest, at that time. We know of his severe pulmonary hypertension, we know of his severe MR, but this were not an issue that we were facing at that time. So we went ahead, and this is the TAVI. So this is a single video, we'll leave it running. So access established as usual, ultrasound guided. We checked the stent to make sure things are okay, and they were okay, no issues. We took our images, confirmed the angles, and then basically crossed, and after crossing, we basically went ahead with the 26 FX evolute, and we just bringing it around the arch. There's some calcification around the arch, but that was not a problem. So we'll wait for this. So we basically crossed. Everything so far is fine, no issues. We confirmed our position. This is basically the overlap view, and we kind of pulled the valve a little bit up and then deployed here. We had good results right away after that. Just show you here when we deployed the valve, and we had no issues after this in terms of paravalvular leak, nothing like that. So we just took this picture so you don't see any significant paravalvular leak, nothing else. Okay. So moving on. So this is his hemodynamics. So this is hemodynamics when we started on the left. So blood pressure around 120, and this is the gradient across the aortic valve, a gradient of almost 50. Even though we didn't show it on the echo, but this is a confirmation of what his hemodynamic like. And then after we did the valve, and we just recrossed to get the gradient. There's no gradient, but what we can see right away, he's quite brady. His heart rate is almost 30 to 40. His systolic blood pressure is around 80. So the guy is basically, we're thinking, okay, this is now he's going into complete heart block. This is the pictures. We start pacing, but the blood pressure is not picking up, and we are losing him literally within 1 minute of everything being fine into almost I'm having a patient arresting on us. So, I'm going through my algorithm, okay, we give him fluids, we give him pressors, thinking, okay, so did we obstruct anything? I already checked the coronaries, there is no coronary obstruction. We call him for echo, we want to make sure there is no pericardial effusion. We didn't rupture, there is chance of rupturing, those patients are very small. But this is the common thing we get the algorithm, coronary obstruction, rupture for the annulus, perforation, the common thing. So we checked for all of that, okay? Here, just another picture, so just to make sure there is nothing, everything is fine, and we don't find anything. So we've been given him, we only managed to get the blood pressure up with epinephrine boluses, not just norepinephrine or phenylephrine. We had to use actually epinephrine. And you could see the blood pressure. One thing we noticed, and I'll show you here, when we were doing the echo, RV is very dilated and severely depressed. So we went ahead and did an RV. So if we just get the images for 1 minute. So we went ahead and we did white heart cath, and we were monitoring the blood pressure. So whenever you give epinephrine, you will raise your pulmonary artery pressure as well as that. But the moment everything settles, look at the image, and then you start to get the PA pressure exceeding the systolic pressure. This is like real life hemodynamics physiology happening in front of you. The moment the PA is now higher than that, the RV starts to dilate, pushes against an LV that is already small, and basically creating an LV suicide, and it just become going down from there, a spiral. So we go again, we give epi, we get everything's up, we had to get the blood pressure up, but we needed to support the LV, we needed to give more fluid on, and we needed to basically increase the afterload, because the severe AS itself was protective against the severe pulmonary hypertension. And the moment we took that away, the RV now is pushing against the LV, and the LV is already small, so it gave it not your typical LV suicide picture where you actually have a cavity gradient. Is actually because of the effect of the RV as well in this situation. So we had to intubate the patient, we had to put them in milrinone, and we had to take him intubated and basically trying to get some nitrous oxide for 48 hours until things settled, and we got him out of it. The challenge in this case, to be honest, that we didn't foresee is that the effect of pulmonary hypertension will be so severe if you already have a significant concentric LVH. The surgeons are very familiar with this pattern, because when they take patients and they replace the aortic valve, some of them will have an acute RV failure and they have to leave on an RVAD at the same time. So we don't see that quite often. We kind of see those patients are protected, but this is one of the cases where we have a concomitant severe pulmonary hypertension causing an LV suicide at the same time. It took us, as I said, 48 hours to get him out of that, but then yes,
just an extra minute for the slides, please.
So Basically, LV suicide, isolated LV suicide is rare, but it could happen. It could happen basically whenever you have a significant LVOT obstruction because of the septum growth, and if patient is dehydrated, so a preload is reduced. So in order to mitigate that, you need to make sure you fill the patient very well, and you increase the afterload. Basically, it's like a Hockham case. You're trying to increase the afterload, increase the preload. So using purely alpha blocker like phenylephrine would work in those patients. You could consider using pacing. Pacing will help in those patients if it's purely an LV issues, but in this case, it wasn't helping, to be honest. And alcohol septal ablation, I think doing that on the spot is really nightmare to do, especially in those cases, so you shouldn't have to do it unless you really have to. And if you really anticipate that, it should have been done before. And last is ECMO, and I think if ECMO was available to us at that time, we would have to consider it, but we managed without it. So this is a different case of LV suicide triggered by severe pulmonary hypertension. Thank you.
Interesting case, it's not suicidal LV as much as what they call it acute decompression syndrome, reported in the literature in patients with severe pulmonary hypertension when they have pericardial effusion, and you do pericardicentesis and the reverse Bernheim effect, it pushes the LV because of you are decompressing the RV from the restraint from the pericardial effusion. For this reason, patients with severe pulmonary hypertension, when they have pericardial effusion, think twice before aspirating and do decompression. So this is an acute decompression rather than LV suicide.
Thank you, Abdulrahman. Nice. I agree with you, Muhammad. You see, if you look to the, this is probably another explanation, but if you look to the cardiac, to the blood pressure or the cardiac output, stroke volume times the heart rate. The moment you remove the afterload by removing the AS, the right ventricle, which was the left, the AS was protective, as you said. Yeah. There is interdependence of the ventricle, of the interventricular septum. So the LV became small, and he's already bradycardiac. He dropped his cardiac output. He dropped his blood pressure. That's why he responded to epinephrine. If it was a true suicide, he won't respond to epinephrine and make it worse. But I think this is very useful for that when there is pulmonary hypertension, you have to be prepared for low cardiac output state.
Excellent. Professor or Dr. Talal?
Yeah, I just want to ask, did you guys try rapid RV pacing? Like one of the preventive measures that have been described, if patient crash on you on the table, you can just rapidly pace the RV.
We did pace, but not rapidly. Like, it was something like 150 or so. It's just basically to get him. It took us a while. Honestly, I think the challenge at the beginning is at the moment is trying to figure out what's going on. Like you everything commonly that you deal with in terms of the hypertension is not there, and then you think of LV suicide, but then you don't have really a very bad septum to cause that. Like you're not creating interventricular gradient. So we had to fix the patient on the go while trying to figure it out. So eventually we knew this is pulmonary hypertension driven, but we do a lot of cases with severe pulmonary hypertension. Like who will get this problem and who was not is something I don't understand yet, to be honest. And I don't know if anyone understands which patient will suffer from this and which will not. I don't.
In the, I would say, 2010-12 cardiac anesthesia used to meticulously ask for right and left heart cath, and for patients with pulmonary hypertension, they have mirror already. But I agree with you, how many times we do a right and left heart cath before a TAVI procedure? In this case, probably this is something related to pulmonary hypertension, but nowadays, unless you really pick it, my rule has been always fill the LV to avoid this situation. But this would be a very interesting case. And the second part, I want to ask you, what happened to the MR? Because this guy also can... Yes.
So the MR actually didn't get worse. So the MR actually got better in a way. So we were looking for that to see if it truly was going to be a SAM-like appearance, especially he had a flail, partially flail leaflet, it will become worse, but it wasn't. So it wasn't driving the whole things in this situation.
When I was in Toronto in 2014-15, we were reviewing all the TAVI cases done in St. Michael Hospital it was a plan to publish the data for the effect on the RV post-TAVI. Unfortunately, it was not published, but what I noticed that there is a trend post-TAVI, there is maybe some increase in the TR and increase in the pulmonary arterial pressure. One of the explanation was I was thinking is the septal shift, because you are removing all the pressure in the LV, and the RV, the interventricular septum, like what Dr. Muhammad said, the interventricular independence, it will shift and it will increase the TR and the pulmonary arterial pressure. That was the explanation. Unfortunately, that data was not published, although it was.
And I remember in 2010 where Swan-Ganz was part of the procedure. So you start your TAVI but you assess the pulmonary pressure and you see what's happened. And this is one of the things that it get disappeared as we go. Excellent case, Dr. Abdulrahman.